We've looked at women in the case of Amy Tendrich being activators of communities and really taking a lead on a global level of activating patient communities. We obviously just heard from these female leaders and Leslie in that panel about how we should think about women as consumers of healthcare, not just women as patients, but women as consumers of healthcare in the context of decision making for their families. What we're going to talk about now is women in clinical trials, and for those of us who've been in healthcare for a long time on the industry side, this is a topic that we've actually talked about for, I would say, decades at this point. I'm not sure that we ever fully crack that nut in a meaningful way in any given single company, but I think there's been success stories along the way, particularly from the provider side, about what matters and how you could do things differently and how we should think about women in clinical trials today in 2015. So, my good friend Anna Abreu, who's a principal in her own consulting company, is going to lead panel 2 in this conversation. If you look down the row here, I think that you'll find there are some incredibly esteemed panelists that have come from all over the country to be a part of this conversation. And Jessica Hudak, it's worthwhile thanking her in front of everybody who is managing our AV situation today, which is thankless, I know. Yeah. But with that, I will actually turn it over to Ann to introduce the panelists and listen to your insights.
Excellent. Thank you, Joe. So I woke my daughter up this morning as I was leaving. It's just a funny story because, growing future women leaders and leaders who, I always tell her I wanted to be a leader, not a woman leader, but just a leader who happened to be a woman. And so I woke her up this morning as I'm walking out the door to come and do our morning tech check, and she's 12 and she's sleepily lying in bed. And she literally, as I'm walking out of the room, she's like, "Mom," and I'm like, "Yeah," and she's like, "Whatever it is you're going to do today, win." I thought it was so cute. So I was like, all right, we'll go for that. Anyway, shortly after I was invited to moderate this panel, I attended the Lead On Silicon Valley conference earlier this year. I'm not sure if any of you were there or not. It was a fantastic conference with 5,000 women. Hillary Rodham Clinton was a keynote speaker at lunch. It was really great. At that conference, I saw Richard Carmona, the 17th Surgeon General of the United States, speak. I saw John Gray of Mars and Venus fame, and then obviously I saw Hillary Rodham Clinton do the keynote. And the thing that really struck me, and I saw some others, but the thing that really struck me was that of those 3 speakers, each one of them touched on the discrepancy between data in women in clinical trials. So Richard Carmona actually said, as it stands, women are at a disadvantage because almost all the studies are done for middle-aged white guys. So that's a problem, right? Hillary Clinton, not surprisingly, spoke more on a budget policy area, and she talked a lot about how, she kind of touched on breast cancer because that's obviously an issue that many women are interested in, and how the breast cancer budget actually at one point in time had to be hidden in the defense budget because then it wouldn't be cut, which I found, as a breast cancer survivor myself, really shocking. And John Gray, I don't actually have a clever quote from him or anything. I just found it really fascinating that he, as an author, was actually getting into the clinical realm, and that it came up 3 times in one day, 4 days after I was invited to do this panel. It's a hot topic, so let's get to it. Firstly, my co-pilot in organizing this panel is Janie Mandrusov. I don't know where you are, Janie. There she is. And we've had so much fun organizing, and I think we have an amazing lineup for you guys. So we're going to do it a little bit differently. We have different perspectives sitting up here, and each person up here is so amazingly accomplished that I don't think I can do. Well, first of all, I'm kind of having moderator envy. I don't know their childhood aspirations or their superpowers. I'm sorry. Leslie, I'm annoyed. I know Leslie. So anyway, but I do know that they are amazingly accomplished women, each in their own right. We have 3 physicians, a radiation oncologist, yeah, cardiologist, and an orthopedic surgeon. And each of them is amazing in their accomplishments. And then we have a senior health advisor from the FDA and a VP of regulatory and clinical. So Joanne Whitus is a vice chair for the Division of Molecular and Cellular Oncology at UCLA. She's also founder of a company called MiraDX that is amazing and bringing insight to oncology in women. So I think it'll be very fascinating to hear from her on that. We have Dr. C. Noel Berry-Mears, two down, who's the director of the Barbara Streisand Women's Heart Center at Cedars-Sinai Medical Center. We have Dr. Kimberly Templeton, who is professor of orthopedic surgery at the University of Kansas. We have Sally Mayer in the green down there, who's the VP of Regulatory and Clinical for the Critical Care Division of Edwards Life Sciences. And we have Nada Hanafi, who's Senior Science Health Advisor from the Food and Drug Administration. So I think we have an amazing representation of perspective here that will be great. Our goal is, I actually had to educate myself a little bit on this topic, and I made an assumption that many other people would too, because it's deeper than I realized when I was invited to do this. And so our goal is actually to start with some education. We'd like to add insight so you all understand what the issue is and why we're talking about it. And the physicians will each do like a 7-minute little TED Talk on their respective areas to show you and elucidate why it's an issue. And then Nada will talk about the FDA perspective, and then I'm going to ping it to Sally to do sort of like an industry reaction to all of that. Then after all that, we have a full panel. After all that, we're going to go and do some Q&A, and hopefully, if we can get the technology to work, make sure it works, we're going to do some interactive. We're going to poll the audience on how your organizations handle gender differences in clinical trials. So with that, I am going to turn it over to, the first person is Dr. Berry-Mears. And I know you have to leave, but I think because we're only on 7 minutes apiece, I think we'll be good. Yeah.
I don't mind switching.
No, that's okay.
Do you want to?
Good, good, thank you.
And I did ask if it was going to be queued up, and they said yes. I was asked to do slides, so.
Yes.
Well, they always say that, professors can't talk without slides. And I said, no, I can talk without slides. And they said, no, we want slides. So I am a cardiologist. I'm a clinical investigator. I do clinical trials. And I also do direct this Women's Heart Center. And I'm also a medical advisor to the Women's Heart Alliance, which is a new advocacy group in part funded by Barbara Streisand and her mission to make sure that all women know that heart disease is their leading healthcare threat, and then that the medical establishment response actually is appropriate. So she's doing a lot of advocacy work. This slide shows 2 diseases and their toll. More women die of CHD, which stands for coronary heart disease, than breast cancer at all ages. And this is an old fact, but it remains alarming, so I still show it. It's real data, it's US data, and you can see in the red bars that more women die of heart disease than breast cancer at all ages. This is shocking because most of us can think of someone we know that has breast cancer. Most of us cannot think of a woman. We've done these polls, our Women's Heart Alliance. Most women can't tell you about someone they know that has heart disease. So we have a recognition problem. And the second, the contributor to that is that heart disease, half of the time when it strikes, it is sudden cardiac death, where breast cancer tends to be slow. And actually, we cure a lot of breast cancer now. Overall mortality or overall survivorship now is around 10 to 12%. So most women now are being cured of their breast cancer, and we get to talk with them, and we get to keep them in our families, where heart disease is quite different. All right, next slide. We have been working a lot on what we call the Yentl Syndrome. And these are 2 very noteworthy women. Of course, you know the one on the right. Is it your right? Yes. That's Barbara Streisand dressed up as the Yentl in her movie. And of course, she had to portray a man to be educated in Eastern Europe at that time. Women were not allowed to be educated, so how did she do that in the movie? She dressed up like a man and therefore got all the rights and privileges of men. The gal on your left, you probably don't know unless you're a part of the federal government. This is Dr. Bernadine Healy, who was our first female director of the National Institutes of Health. She was an investigative cardiologist as well. And she wrote an opinion in the New England Journal of Medicine, which is one of our big journals, that she thought the reason more women now were dying than men of heart disease was that they weren't being recognized because they didn't look like men. They just weren't being recognized. And when you don't get recognized, then you don't get treated, and then you die. So that was something that she opined about in 1991. So let's go fast forward. This is telling the story that in 1984, the red line and the blue line crossed. So in 1984, women became the majority of victims in the United States of heart disease. So this was too quick to be due to genetic change. It's not related to global warming. Risk factors hadn't changed. Women were smoking as much as men in the 1960s, Virginia Slims. Women are not more overweight than men. Actually, more men are overweight than women. So it wasn't accounted for by risk factors. So at the NIH, at that time, 1984, the curves crossed. Next click forward. New female majority. What happened then was in the 90s, it was recognized, and Bernadine Healy wrote about it, and she funded the Women's Health Initiative, and a part of the Women's Health Initiative, which was a very large clinical trial and also an observational cohort study designed to try to make up for over 100 years of the lack of studying women and common diseases in women other than reproduction. There was a small set aside for this women's ischemia syndrome evaluation, next click, which is a study that I've had the honor to chair with continuous funding for the last 20 years. The American Heart Association also at this time started on their Go Red, Wear Red campaign, as did National Heart, Lung, and Blood with their Heart Truth campaign. All right, so, but you could see it wasn't doing very much. The curves were still going up. And again, we would sometimes joke that if this had had anything to do with erectile dysfunction or prostate cancer, it would not have taken 12 years to recognize and take some action. So this is just a cartoon to talk about our subject. So we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anyone. And there's a lot of reasons for that, and I'm sure this is, some legitimate reasons, but a whole bunch of gendered reasons that we would say are not appropriate, weren't appropriate then, are no longer appropriate. So obviously we'll talk about this in the panel. So we've made a number of observations. 20 years is a long time, but I like to say we're at least 50 years behind in understanding women's heart disease the way that we understand men's heart disease. So even if we work as fast as we can and technology helps us, we probably have another couple of decades of investment that need to be made to try to close these gaps. Here's just a couple of things that we found. Women, these are sections, sorry, right before lunch. These are coronary arteries. So these are the arteries that get plugged up. And so if you think of somebody that you know with heart disease, like Bill Clinton or Dick Cheney, they have the bottom ring problem. And it's filled up with plaque, and then it explodes, and that causes a heart attack. Well, one of the things that we were able to describe with Renu Vermani is that women actually erode. They don't explode. So their heart attacks look substantially different. And you might imagine, using a male pattern diagnostic, they're harder to see the erosions. All right, next slide. We've also done with a new technology, it's not so new anymore, called intravascular ultrasound, that women and men appear to lay down fat in their coronary arteries. And again, this is the fatty plaque problem, the Bill Clinton, Dick Cheney problem. Women and men lay it down differently. And if you thought it through, it would make perfect sense to you, because how do men, when they become generally overweight or obese, where do they usually put it? In their belly, right? And really heavy men often look like they're pregnant. Where women, where do we put our fat? Cellulite, right? It's all over. So just on the basis of that, and because we had this new technology, and again, similar to this marketing, just trying to think differently. Could this possibly, be an explanation for why these angiograms don't pick it up? And that's what this diagram shows and what our research has shown. The representative male angiogram is on the top, and it's very lumpy, bumpy, and it's all, bunched up in that particular area in the middle, where the woman just puts it all down the artery. And then with these traditional angiograms, which were developed in men, for men, and by men, you don't see it. You completely miss it. And then the women are not treated. So this is kind of a pictorial that we put together for the European Heart Journal a couple of summers ago. And it is a stick figure, just giving you sort of an idea about the prevalence when you're looking at a heart attack or what we call an acute coronary syndrome. But we'll just keep it simple with heart attack. And that most of these cases have what we call obstructive CAD, which is the male pattern, the Bill Clinton, Dick Cheney. And there are a few women in there, about a third, but more women actually have this female pattern. So it's Barbra Streisand looking like a man versus Barbra Streisand looking like a woman. The Barbra Streisand as a woman to the cardiologist is often missed, just can't see it. And then you can see the little tombstones. You can see where more women are dying. And a lot of this just has to do with recognition, and then they don't get treated with the life-saving drugs because they didn't think it was a heart attack. All right, I'm almost done. All right.
There's some
I know, all my arrows.
Sorry.
There's. All right, so one of the things that we're working on is advanced imaging to pick up this female pattern. And we live in this wonderful age where new stuff comes down all the time, and we've been able to use magnetic resonance imaging, which is not in your doctor's office yet and may never be. But if you can show that it's there and you can show that this is real, because historically this pattern is ignored and women often slowly go crazy because they are ill. There is something wrong with them. They actually are having heart attacks, and yet they're more often not treated. So we've used this to proof of principle, and then there are many modalities now that are coming down the line, very advanced ultrasound, PET scanning, as well as other measures, fingertip probes, et cetera. There are DNA tests now that work better in women than men. So it's going to come. We're also very interested in regenerative therapies, and this is an example of why just an example, it's a poster child of why you absolutely have to have women in studies. When you don't include women, you miss important differences. This is work from Dr. Doris Taylor, where she demonstrated in animals, and now we're moving on to humans. That women, cells from women, regenerative medicine, stem cells, but this is not fetal tissue, so do not worry or get upset about this. This would be your own stem cells. Look at those robust XX stem cells on the top, and look at the out to lunch, not paying attention, not asking for directions, XY stem cells. And she demonstrated very clearly in her animal studies, which again we're now replicating in humans, that female stem cells, and if you really think about it, why are men and women different? What are women really good at? Exactly. No, not organization. Women uniquely can make new life. And so do you think that our engineering and our biochemical makeup might be better at making new cells? Might be, right? And if the current rash of stem cell therapy trials fail because they were exclusively using male cells, we will have missed a whole opportunity to make a very big difference. And her studies would suggest that that's true and that we should be using female stem cells. All right, so here's what's happened, working together, National Heart, Lung, and Blood, American Heart Association, Women's Heart Alliance. There's a lot of heart disease groups now, although we're only bending the curve. We still have a lot of work to do, and I would ask all of you as leaders in your field to, A, remember that heart disease is the leading killer. Number two, we got to do a better job, and you can help. And Barbara will help us as well.
Thank you so much. That was very interesting. I'm going to hand you this so you can, and I know, so Dr. Templeton actually has a hard stop at noon, so we'll go for it.
Sorry
We'll
about
be quick.
that. I have to get back to see patients, unfortunately. So I appreciate this opportunity. Thank you for the invitation. I'm also president-elect of the American Medical Women's Association and chair of a group that's called the Sex and Gender Women's Health Collaborative. And part of the goals of both of those groups is to raise awareness in the health provider community that sex and gender does have a significant impact on all health conditions. So why focusing on osteoarthritis? Osteoarthritis is the most common type of arthritis. It's one of the leading causes of disability, not only in the U.S. but also globally. And joint pain also impacts the ability to take care of other chronic health conditions, such as heart disease, where you may want to recommend exercise as a form of treatment. If patients are hurting, they can't exercise. And so our osteoarthritis is a significant issue. And one of the areas of sex and gender differences that we're getting more aware of in the musculoskeletal community, as you can see from this data from the CDC, as people age, osteoarthritis is much more common in women than it is in men, and that's true for all joints except for the hip joint, and noted most especially in the knee. Why is it more common in women? There have been a lot of risk factors that have been identified, and when we're looking at sex and gender-based medicine, we're looking at risk factors, etiology, presentation, and response to treatment. So what are some of the risk factors for women? And I'll just go through these briefly. One of the issues that we worry about is the risk of joint injury. Anterior cruciate ligament injury or knee injuries are more common in women. They're about 3 to 8 times more common in women. When either men or women sustain a knee joint injury, they damage the articular cartilage, so the lining tissue in the joint. That damage leads to osteoarthritis. The issue with women who sustain joint injuries, and we're seeing more and more of them as women are getting more involved into sports at higher levels, is that women develop osteoarthritis as a result of the knee injury more commonly than they do men, and also much earlier than men. Women will develop symptomatic arthritis about 10 to 15 years earlier than will men. So if you develop your ACL injury when you're 18, you're likely to develop symptomatic osteoarthritis of your knee when you're 25 or 30, which is a significant issue. And this is true even if you have surgery for your ACL. There are also some different anatomic areas, especially around the hip and the knee. Women have somewhat different alignment of their hip, so the socket part, the cup part of the hip can be different. That can lead to changes in how the hip wears. And there are multiple different types of risk factors for osteoarthritis around the knee, all of which have to do with sex-based alignment of the knee. But there also tend to be some very specific sex-based differences in osteoarthritis that go beyond anatomic alignment. Women tend to have more likely to have more joints involved. They are more likely to have more rapid progression of their disease. There are more symptoms. So there seems to be something underlying osteoarthritis in women that tends to be more significant in addition to just the anatomic differences. As with most sex-based things, the first thing we think about are hormones, and is there an impact of hormones? Probably. There appears to be some impact of estrogen. Estrogen helps support the cartilage or lining cells in the joint to make the collagen that's needed to support the joint. It also inhibits the production of chemicals that help break down the joint. So estrogen probably is a joint protector. There are a lot of animal studies that look at the impact of damaging a joint and then either leaving or taking out the ovaries, so affecting the estrogen levels. Those animals where the ovaries have been removed tend to have more rapid progressive loss of cartilage. So there appears to be some impact of estrogen on development of osteoarthritis. The other area where there's a sex-based difference is in muscle strength, probably both sex and gender-based. Women tend to have somewhat weaker muscles than do men. Muscles act also as joint stabilizers, so they keep the joint from abnormal motion, so hopefully helping protect the joint. In this study, they looked at women with osteoarthritis based on X-ray. As you go to the right, that's more significant arthritis noted on X-ray. As the arthritis became more significant, their quadriceps or thigh muscle strength got weaker, and half of these women didn't even have any joint pain, so you can't use that to explain their muscle weakness. So weaker muscles in women may be another explanation why there's increased risk of osteoarthritis. For both women and men, there are a variety of non-surgical options. There are a lot of things that we can do to help with arthritis, but if none of those are efficacious and patients are still having pain that limits their function, the ultimate treatment is going to be a total joint replacement. Unfortunately, we don't have an objective indication for a joint replacement. If patients will come to me and say, do I need a knee? I don't know. It's their life, and I don't know if they need a knee replacement. It really depends on how it's impacting their lives. The problem is, as we've discussed, as has been discussed earlier today, women may not want to come in and complain because there's so many other things that we're trying to do. We may delay seeking of health care. But when you look at some of the gender influences on joint arthroplasty, women have received more joint replacements than do men. However, when you compare that to the number of women who have symptomatic arthritis, there's been an estimated threefold underuse of joint replacements in women than in men. And this is data from 2000. There was a study that was reported last year that shows that although both men and women are receiving more joint replacements, this disparity still exists. In the study from 2000, the patients were interviewed, and women were equally likely to want to undergo an arthroplasty, but basically said their physicians never brought it up. Nobody ever discussed this with them, and they didn't feel empowered to bring it up. So there are issues with just getting women to the point where they may undergo an arthroplasty. And the bias probably exists on both sides. In this study, men were more likely to be referred for a joint replacement than are women, even in the age group of 20 to 39 when we don't do joint replacement. So even men who wouldn't qualify for joint replacement were more likely to be referred than were women. There was another study in 2008 where they had scripted patients that were sent both to primary care and orthopedic surgeons. Men were substantially more likely to receive a recommendation that they needed a joint replacement, even though they had the same history, the same complaints, the same x-rays, and both female and male patients were told to ask their physician at the end of the interview, do I need a new knee? Even with that prompt from the patient, women were 3 times less likely to receive a recommendation that they needed a joint arthroplasty. So there seems to be some bias in the medical community, and it may be conscious or unconscious. As we'll talk about, there are lots of studies that show that women don't do as well after they receive a knee replacement as do men, or even a hip replacement. Maybe physicians think that their prior patients didn't do as well, so why bother to refer them? Hard to know what some of the bias is. But there are also issues from the patient side. In this study, men were willing to undergo a joint replacement when they could no longer perform vigorous outdoor activity, i.e. if they couldn't play golf, they wanted their joint replaced. Women in the study were more likely to be limited to just indoor ambulation by the time they thought that they were ready for a joint replacement. So it's issues on both sides. The problem is, as you wait longer and longer before the joint replacement, patients tend to be in much worse condition. And so although both men and women get better after the joint replacement, women still lag behind because you have so much room to make up by the time they ever undergo any sort of surgery. So women don't do as well. If you look specifically at knee and hip, why don't they do as well? So again, it's the issue that they're in worse shape before they come in. There's more room to make up. But there's also concern, is there a sex-based impact from this? As we discussed, the anatomy is different, especially when you look at the anatomy of the knee. The women knee from side to side is smaller than it is for given front to back measurements, so the knee measurement's different. The front of the knee doesn't tend to be as prominent. These devices were primarily designed for men, so maybe the implants are just too big for women. If you look at the charts on the right, the top is men, the bottom is women. The colored dots are the sizes of the implants. And the black line is sort of the average size of the joint. So what you can see from the top is that although the implants don't fit men, if you compare it to the bottom graph, they fit men better than they do women. So the thought is maybe we need to design an implant that's designed just for women, so called gender-specific implant, although it's more sex-specific implant, that had different measurements both front to back and side to side. But we're not sure if that's made a difference. Studies have been both pro and con, but in a study published last year, which is a meta-analysis of randomized clinical trials, actually found that if you compare gender-specific head-to-head with standard implants, there's no difference in pain, range of motion, knee scores, patient satisfaction, complications. So actually changing the size of the implant doesn't seem to help outcomes. And so we may be getting back more to the gender issues of getting women to their ultimate treatment earlier on. And it really is an issue not so much of whether you're male or female, but how big you are. This is probably more based on size than on sex. There are similar issues with total hips, although there isn't as much anatomic variation between men and women in hips. So people really aren't seriously discussing a gender or sex-specific hip arthroplasty. But with hips too, we notice that women don't do as well as men after surgery. Again, probably issues of how debilitated they are at the time of surgery. But the one thing that we do see is that women are more likely to have joint replacements around the hip that fail. In this study that was published in 2013, women were almost 30% at higher risk of having an aseptic or non-infected hip failure. Initially, that was thought because women are smaller, they need smaller implants, maybe the hip dislocates more frequently. If you control for hip size, that actually doesn't hold up. But what was found is if you take out the segment of the population that has what's called a metal-on-metal hip, so both the ball and the socket are metal, they're significantly more likely to undergo failure. Most joints are either metal and plastic or they're ceramic. Metal and metal is a newer type that's getting more and more traction in the US. And so what was found in this is that women were having issues with metal-on-metal arthroplasty. And this has been confirmed in other studies. And so this is one of the few implants in orthopedics where there's really been a prohibition on using this in women because there are metal ions that are released when you articulate metal on metal, something that we couldn't find out in the lab, something you're only going to find out with a certain amount of wear with day-to-day use. This leads to a lot of reaction, and it's thought maybe women with an increased inflammatory response are responding to these metal ions, and this is causing failure of the implants. So, thank you.
Thank you. Thank you so much.
Thank you.
Dr. Williams, please.
Okay.
You're next. If you hit next, your slide is up.
All right, the big green button. Maybe. There we go. Hi, I'm Joanne Wheatus. I appreciate the opportunity to present to everyone. My talk's a little different. I'm an academic as well, radiation oncologist, but also geneticist, and have founded a company. So how many people in this room think they will get cancer? You can just nod or raise your hand. Okay, so a third of women, 1 in 3 women actually develop cancer in their lifetime. And you look around and you think, not this group, man, we're all healthy and strong, we take vitamins, we exercise. But I had a whole lot of female breast cancer patients that looks just like everybody here, and we're too young. But women are different in cancer. It's not the same. And really the number one risk factor for cancer, which no one really wants to hear, is a family history of cancer. I mean, you can modify things and live a healthy life, but I never had a cancer patient who wasn't completely surprised. Nobody thinks they're going to get cancer. So, as I mentioned, my background, I'm a radiation oncologist. I'm also a scientist. And with that understanding and seeing these women patients every day, we really worked hard to try to understand what these differences were. There isn't a comparable cancer for men as breast cancer in women. You don't get cancer in your 30s and 40s and even 50s. Most people, 75% of people get cancer over 55. That's not true for women. There's a lot of younger women. So we knew there were other genetic markers. There have been very few available. And in 2007, in collaboration with a group at Yale, we discovered a new class of marker and noticed right away it's a different type of biology. I won't even go into it about how it works. But it was a much stronger marker of cancer for women than it was for men. Sure, we studied every cancer, but we first found in lung it's about 3 times more likely for a woman with this marker to get lung cancer than a man, even though as many men have it as women. And then we really saw a strong predictor for breast and ovarian cancer. So what's different? Just as many men have it. Well, it turns out that this marker, this type of marker, is really affected by things you do in life. So it really does matter if you're thin and healthy and what you eat. But the strongest thing that is different between men and women is estrogen, and that hugely impacts this marker. And what's interesting is what we as women have accepted as normal management of our estrogen. I guarantee everyone in this room has done something on this side besides pregnancy. Birth control pills, I think everyone just hops on and off birth control pills, which is really yanking around your estrogen. People do in vitro fertilization without back and forth, is that a risk for cancer? The huge swings in hormones. I mean, that is not normal, physiologic. Having your ovaries out and going cold turkey without estrogen, starting on hormone replacement and then stopping suddenly because the huge study came out saying it's bad and everyone has to go off of it. The second question, how many people how many people here think hormone replacement therapy, estrogen, is bad? So, depending on the population, the truth is everybody thought that in about 2003, after everyone used to think it was good. It has been back and forth. And the truth is it's not bad for everyone. Estrogen's a really positive thing. And for some people, it can be very good. So, what we found with our marker is that for women that have it, which are about 1 in 10 Caucasian women, 1 in 17 women in the population, estrogen, maintaining a regular estrogen level is actually very protective against cancer. Really opposite of what people think. And what we do with estrogen is there's nothing like it. And what the medical establishment recommends for women without thinking about yanking around estrogen is astounding. We don't do that with men's testosterone. That would never happen. So the question is, we knew this now. We know this. This has been after years of study where we have engaged a lot of women. And we had to. We had to get these answers by working with women, getting really detailed information that a woman can tell you, oh, yeah, I was on birth control pill, this many pregnancies, I tried hormone replacement, I stopped it. Those are questions that aren't always picked up in general studies. So we launched some of our own. I'm going to tell you about how we did that, how we reached them. Because this was very challenging. So bringing a marker for women, particularly that predicts cancer risk, it is just fraught with impossible brick walls and mountains and all types of stuff. And I think we ran into them all pretty hard. And we don't have to go, as people from companies, I mean, there's, besides regulatory issues, there's the doctors, the funding, insurance, which doesn't really want to pay for insurance, insurance against disease or prevention. So these were things that we all thought, God, this is insurmountable, really insurmountable. How can we get this information to women? Doctors don't seem to care. But the opportunity was too strong. I mean, it's too important. And as a cancer doctor, and I'm sure everyone in this room knows and has loved somebody that's died of cancer, avoiding cancer is really the best thing. I mean, sure, we could get funded for treating it. We have a drug development program going on, but let's just not get it. That's clearly the best option. So, we had to figure out a way. We had to figure out a way to get answers and develop a relationship with women to help develop these answers, but maintain this relationship because it's a management. It's not a one-time product buy. It's not a, one-time test, although it is, but it's really a lifelong partnership in managing cancer risk and decreasing it. So this is what we've done. So we started in 2010. We launched a CLIA lab that allowed us to test and return genetic information. And after hitting some of those brick walls, we actually adjusted pricing and did SurveyMonkey, great suggestion. We've done quite a lot of them. Talked directly with women, engaged a 2,000-woman study, which I answered probably 50,000 emails. Women, it's great to communicate by emails. I mean, thousands and thousands of emails, communication. Adjusted price accordingly, what was affordable, to allow all women access that are interested in this information, be that breast cancer survivors who are very motivated to find out why, make sure it doesn't happen to people they love, but their family members, other people touched by cancer. But I think more importantly, to our for-profit company, we have launched a sister nonprofit. And MiraKind, it takes away the lack of trust. Through MiraKind, we've run our patient-centric studies. It's a source of education and information and outreach. People can join a study. They don't need to know. If they don't want to know if they have the KRAS variant, they don't have to, but they're still participating and making a difference for the people they love, for other breast cancer survivors. And we've just had incredible uptake of this through social media channels. This has come up, through Facebook. Women talk to each other, and the trust is really critically important. And it's come up, as a company, how do you approach a woman? As a physician, I'm really comfortable talking to women about breast cancer risk, things like that. And I think that's helped, and we try to build an organization with people, that's their approach. They want to be inclusive. So, and importantly, through Miracon, we also have interactive webinars. You know, we share publications. If someone's been involved in a study, we share that publication and give a synopsis. What did you help find an answer to? And we let women help decide what the next study should be. So that's been our approach. It's a little bit different. It's really incorporated a lot of what people talked about today. I love to say we planned that, but actually it was after a couple brick walls we kind of got here. But it's had great uptake, and I'd encourage people to think about it. It's really just engaging women in figuring out what's important to them, knowing your consumer right, but with the mission of finding answers together. So,
Great. Thank you so much.
Thanks.
We're going to pass the
clicker.
clicker down to Nada.
Well, hi, my name's Neda, and I'm really excited to be here. And I have to thank Amy and Deb, who I connected with about 2 years ago, for inviting FDA and allowing us to offer perspective. I think it's really important that we're having this discussion about the appropriate inclusion of women in clinical studies so that we can assess clinically meaningful sex differences and outcomes. So I thought I'd give a high-level overview of who FDA is. We're made up of 7 different centers, and we provide regulatory oversight over a variety of products that range from pharmaceuticals, vaccines, cosmetics, of course, medical devices, which is the center I come from, and then our newest member to the family is the Center for Tobacco. Our role at CDRH is to ensure that we get safe and effective devices to market in a timely manner. And we want to make sure that once they get to market, they remain safe and effective. And of course, we want to provide science-based, accurate information to you, public, physicians, practitioners, patients, to make informed decisions about your health care. So when we look at the medical device development paradigm, we're considering the total product life cycle. We're looking at it from the discovery ideation phase right through to launching your product onto the market, and then the post-market monitoring. And we see medical device development slightly different to the drug development because it's an iterative process and it moves forward through innovation, which can feed into any area within this cycle to inform additional development as well as our regulatory decision-making. Which leads me to why we need to focus on women. There are unique issues in the regulation of devices used in women, and everybody's touched on this today, especially the doctors on the panel. And you see the upside down triangle or inverted triangle because we think the majority of the issue lies in the uncertainty of the utilization of devices and outcomes because women have historically been underrepresented in clinical studies. And on top of that, there's inconsistent analysis of data or sex-specific data. There's also, as we've talked about it, baseline differences in women related to anatomy, physiology, in terms of risks, disease risk factors, comorbidities, and so forth, which will lead to differences in outcomes in the use of devices. And of course, the first panel discussed this in a lot of detail. Women have different health-seeking behaviors, and how we communicate to them needs to be tailored. We need to be more specific in the benefit-risk information provided to women on the use of devices. And of course, the effects of hormones, we just heard about that, and that's throughout the lifespan, and including the start of menarche through to menopause, as well as the introduction of hormone replacement therapy, which raises additional risks. And of course, there's ongoing risks about the use of devices in women of childbearing potential, as well as women who may be pregnant. And maybe pregnant, that's it. So I wanted to talk a little bit about some of the differences we've seen in outcomes. One of the safety differences was, Dr. Templeton spoke about this, was in the use of the metal-on-metal hips. And we saw in the data that women tended to do worse, and there were higher revision rates for women. And then in the cardiovascular arena, we saw that women also did worse with the use of the ventricular assist devices. They had higher rates of strokes, which of course influences the overall survival, as well as a higher rate of bleeding than men. And the question is that it could be related to sex or other covariates, including the body mismatch. There were also differences in treatment effects, so safety as well as effectiveness. And here it was for the cardiac resynchronization therapy to treat heart failure patients with the use of pacemakers. And actually, FDA asked the company to do a sex-specific analysis. And when they did this, they found out that women fared better than men, which of course could be a marketing incentive. So it speaks to the importance of performing this sex-specific analysis. Another area of a better effectiveness outcome was with the use of the thorax length device to treat gastroesophageal reflux disease. And again, here we found that for both primary and secondary effectiveness endpoints, women did do better. So the reason for these safety and effectiveness outcomes differences, it's hypothesis generating, and we need to have more research focused on the differences in sex outcomes. So part of our policy development or policy strides was we just issued our guidance document on the evaluation of sex-specific data in medical clinical studies. And the guidance outlines recommendations on strategies to enhance participation. That's both the recruitment and retention of women in studies. It also talks about the consistent analysis of sex-specific data and how we can transparently report this to the public so you can make better informed decisions about your health. Just wanted to provide the references to our guidance document, as well as there's a lot of effort within the agency as a whole to look at the collection and analysis of additional demographic data, such as race and ethnicity, and to start to report this out. I thank you for your time, and I'm excited about the discussion.
Great, thank you. Before we start our Q&A, I actually want to turn this to our industry representative, Sally, and say, okay, so you're on an industry work group, is my understanding of this, and I would love if you could just take a couple, and I may just burn straight into the Q&A, I don't know, take your, like, as industry, what can we do to address these and work with the medical community as well as the regulatory community?
So about 6 months ago, this is an issue that when I was in the orthopedic world, I saw and I looked at a lot. Moved into critical care, didn't pay much attention to it, and was asked by our CEO to serve on an ad hoc working group with AdvaMed on inclusion of women in cardiovascular clinical studies. Something I really didn't know much about, but I got to do a deep dive in. And what we found is, or what I have found from paying attention to it now, is that the harder problem is getting patients to enroll. I mean, there is a higher dropout level, there is other things, but some of it is kind of simplistic. If you go to the FDA website, there's a big brochure on, or a small brochure on enrolling in clinical studies that make sure people understand that they're not being guinea pigs, they're going to get the same care, et cetera. But if you read it, it is not geared towards women and is not geared to being a marketing brochure at all. It's a sort of list of facts that doesn't do anything at all. So one of the things this working group thought we could look at is how to develop more education for women so that they actually want to enroll in studies, so that doctors who are going to talk to them about enrolling studies don't get the litany of questions that they may not get from men who don't necessarily always read the informed consent in as much detail as they should, or are less concerned about how they're going to get to follow-up because the wife will always take them, et cetera. So to put it together in black and white, and is for us as industry to really think about how we're doing our follow-up, how we're trying to get patients enrolled. Is it better to have the primary care physician be able to do some of the follow-up instead of them having to go back to the medical center where the procedure was taken care of? And so we've been working through that whole thing. We've had one meeting with a few clinicians as well to really look at how industry can help get women diagnosed faster. I did a study recently, which I'm not going to go into detail on, but there should have been no difference. It should have ended up 50-50. It ended up 20-80, women to men. And so me now being hypersensitive, I looked at my director of clinical and said, well, why? It just doesn't make sense. And he said, but Sally, that actually is the percentage of women to men that were being seen by these doctors. So therefore, we're right on track for what is the the ratio that would have been available. If we want more women than men or equal amounts, you need to work on something to get them to the doctor's office first so they can be offered the opportunity. And I think that's where we as industry can really make a difference by trying to work with how we do our clinical studies. If you don't need to do 15 follow-up visits, then take it down to 5 or 10. If you can have them followed up at a local center, do it there. And it helps the men and the women, quite honestly, but it might make more women willing to sign up for studies. I've been asked to be in studies before, being a trauma patient. My father signed me up for a study because I was a trauma patient. And the minute I got out of the hospital and found out what he'd done, I unenrolled myself because I just didn't have time to deal with that. And I think we pay more attention to that sometimes than men do. And I think it's up to us as industry to try and figure out how to make it easier for women to enroll in studies and how to diagnose their illnesses faster, especially in the cardiovascular side, to get them to the doctors to be given the opportunity.
In one of our planning calls, you had some interesting perspective on requirement of women in studies, and I am
not necessarily a fan of enforced quotas of saying you have to have 50% of your patients women in the study. And I'm not a fan of it because I think in the instance I just brought up where it was exactly equal to the patients that were being seen by the doctor, it would actually skew the results in the wrong way. I think it would also give the potential for seriously delaying promising products being available on the market. That's not to say I don't think it's important to follow these things in post-market. Metal on metal hips is something that's near and dear to my heart since my wife has 2 of them. So I pay attention to that. I do a lot of scrutiny on it. I did the 510Ks for him, so I can't be too, but anyway, it's something we all need to pay attention to, and I think, but if you do a black and white of, I've heard some clinicians say industry should make sure that they have 50-50. Well, if you don't see the doctors, we can't force it in there, so it's how we educate primary care physicians to refer people into centers.
Awesome, thank you. So we have the intent of doing an interactive polling of the audience. We tested it out this morning and it worked, and as I'm looking at this computer, I'm not convinced it's going to work. So I'm going to forward one slide and see what shows up, and we only have 2.5 minutes left, so if it doesn't show up right, I'm not going to fiddle. I'm going to just go to some extra questions that we have for the panel.
Could I do a counterpoint while you're trying to get it up?
It's working.
It's working. Okay.
Okay, so what are the biggest obstacles or barriers to recruiting and retaining women in clinical trials? So if you want to respond, just text MedtechVision to 22333 just to join, and then just do free-form answers.
The biggest obstacle is that the clinical trials are designed for Bill Clinton and Dick Cheney, and so women are not perceived as being eligible, they're not asked. And when we designed our WISE studies using female phenotype, we've had no trouble recruiting, and in fact, we'll be presenting our WISE, a late breaker, at the November AHA, and hopefully we'll be in JAMA. So the problem, again, is similar to what the marketing people told us this morning. The women will participate if they are asked. They're not asked.
Do you have thought, as people are doing this, we may not get, we're on such tight, we may not get responses, but.
I was just going to say, I've never, ever had a problem recruiting. I think women are incredibly willing participants in studies. I mean, they were women-specific studies, so there was no bias in my
And for example, the left bundle branch block sub-analysis that you asked them to do, and I wrote an editorial to that clinical trial, the reason it works better in women is women's hearts are smaller, so by the time they meet the criteria for abnormality, they are sicker than the men. So see, once again, we're just using everything in men, for men, and by men. The Ambien dose, male dose. It just goes on and on and on, and you should be really angry about it.
Yeah.
I am going to actually switch to a different question, just because we only have, does your organization promote/encourage clinical trial design that differentiate the outcomes from male versus female? And if you've already registered, you can do it. If you don't, always. Oh, that's interesting.
Sometimes never. Keep going. Never. You have to.
It's like a race.
That's kind of fun.
We're so different.
Okay. So.
The number of people that voted or the percentage?
And then in our
It's the
last 10
number.
seconds, I'm going to do one more. It's just interesting to me that it's kind of all over the board, you know? The fact that there's both nevers and always is fascinating to me, because that means we have space to go. Okay, so does your organization actively consider whether or not it is inadvertently introducing bias through the inclusion and exclusion criteria? Never and always are our answers so far. N of 3. I mean, it's probably not quite as rigorous as it could be. And there's no sometimes. It's, oh, there we go.
Please don't always know.
So we have some room to move on this, I think. Hopefully we have 30 seconds left. I would love to, does anyone have any questions, like really quick questions for the panel, or should we?
Check for
Oh, it's actually counting up. I'm sorry, we're over it by 30 seconds. but-
Hi. So I have a question about social media, clinicians using social media both as a research tool and as what, before, during, and after the trial, as well as just a recruiting tool. To your point about, like, women just need to know about these trials, and I'm sure they would happily participate. We don't know about them. How do you find out about them? It's not easy.
Yeah, so I would say for us, we actually had a recommendation to post the clinical trial on breastcancer.org, and that directed people to the website. Through our website, MirrorKind, we actually have an eligibility survey that lets people join trials that are appropriate to them. So, that's shared through Facebook. So it's bringing people to the site to find out about the studies, the different ones we're doing, and we let people vote on what's important to you. And we try to educate through that means. It is difficult otherwise.
And that's one of the things we discussed at the working group with AdvaMed, to try to work with, like, a lot of the different heart organizations in particular for social media, to try and encourage women to look for the studies, to let them know the studies that are out there, to encourage them to enroll.
But a lot of it's word of mouth. I mean, I think if we polled, which we probably should, probably 90% of people have found us through a recommendation of another woman. So, I mean, that.
I'm chairing a long-term follow-up of women that had preterm complications of pregnancy to see how well it predicts cardiovascular disease in the future. And about half of our it's a big multi-center study of 10,000 women first pregnancies. About half of the ethical review boards will not allow the sites to use social media.
Really?
So, research, you think healthcare is highly regulated? Research is really regulated, and we have a big issue right now, lots of controversy about whether or not we should have centralized ethical review boards, so we have a sort of a common, and that's probably not going to happen. It's like state rights.
Yeah. We're officially over, so I thank you guys so much to the panelists. Thank you for all of your insights, and
Time for lunch.